The basic components, the three important components, that is the link joints, the connecting rods and the hinges. The whole of the system can be made by these three components only. Tips for applying, as for any other K-wire, you need to put, so the tips are that you have to put the K-wire in a position where the muscle is in maximum functional length. Suppose you are putting in a finger, so it should be flexed, it should not be extended, so that the tendons don't get entrapped between the K-wires. Otherwise, the problem will be that it will be limitation of the movement. Second is always use a high torque and a low speed. Don't use a very high speed power drills because this will cause a lot of bone necrosis. Third is always use K-wires. In JESS, we always recommend to use K-wires because in threaded wires you will be impaling the soft tissue as well. So in the K-wires it is not. Secondly, the thermal necrosis is less. And then always select proper pin position and a geometry of the frame. So just don't keep on putting the wires, but you need to understand where to put wires. So I'll quickly divide my talk into proximal humerus, the forearm and the hand, because these are the places where it can be used. Now you see this is a 72 years male with a 3 weeks old closed fracture proximal humerus, right? So this is the frame, how it looks clinically. It's a very stable frame if put properly. So once you can mobilize the patient from day one. As soon as you fix it, it's such a stable fixator that you can. You see this down 6 weeks, whole of the full movements are there on the shoulder. So shoulder, if you are opening it and doing, if not respecting the soft tissue, it gives very bad results. So the beauty of this system is that you can use it without opening the fractures. You can use the K-wires as a joystick in reduction of the fractures. So another case, very interesting, post-seizure bilateral fracture dislocation of the shoulders. The patient landed to us after almost a week when one attempted open reduction was done somewhere outside. And now the wound is infected. So he presented 7 days and the fracture was not reduced and the patient was from table shifted to a higher center so that the brachial artery is very close to the fracture, so we need to be careful about it. Therefore, they were not having vascular surgeons. So we got the arteriography done, CT, angiogram, and then we opened it, reduced it and fixed it. The whole of the GT was gone, but it was an infected wound with pus. We were not having any other option other than putting this system. On the other side, we did a Phellos plate as a standard plate. Patient was quite young. And you see, this is the follow-up. The fracture has united. Although the movement is not very great on the right side, but still he could do all his activities. So in such cases where there is a fracture which is open or infected, in this the system works very well. Another case, closed fracture, right proximal humerus, almost an intra-articular fracture. We did not open it, reduced it. You can see the reduction and the result. This is only 6 weeks result. Another case, you see, whole of the head is totally displaced. So you just put a wire, use it as a joystick, reduce it, and you can get a wonderful reduction and a beautiful result. Okay, so these are very, means the patient, those who are having a lot of comorbidities, diabetics, or they are not fit for the GA, they can be put in local anesthesia as well. So another case, open fracture, humerus, road traffic accidents. So what we did, we just debrided it properly and put it a fixator. Again the result. Another case, open fracture, infected wound, presented to us with this. The other option was we keep on giving him plaster, the antibiotics and plaster, but we were not sure about the infection. We opened it, debrided it, put a nail on top of that, we put a fixator and it healed well. Wrist fractures, again it is a very good tool because these fractures usually they get reduced by ligamento-taxis principle. So you can put the JESS fixator like this and you can reduce any type of a fracture. Especially, I'll show you again this fracture, 12 days old, infected wound. We could have done nothing, so we just reduced it and put a fixator and everything healed well. Now the JESS in hand, so again it started from hand injuries actually. So if we see, there are different types of frames which we use. So So this is a static frame for the distal fractures. You put an axial wire and you use a static frame which is U-shaped, and the rest of the joints are very mobile and you can mobilize them. So the stiffness problem is very less. In comminuted proximal fragments, you can use a delta frame in which you can put biplanar JESS fixators, right? If the space is too less of the proximal fragment, you can use 2 wires by putting this. Now this is a metacarpal fracture with a J frame. Again the same principle, you can put 2 wires, bend the wire and you can fix this. This is a very reasonable, very cheap system. So you should have this in your armamentarium. Now again an L frame, if it is an intra-articular and you want to cross the joint, you can use this. Again a linear frame, if it is a transverse fracture and if it is open, infected, or an old, you can open it and reduce it and do it. Another case, 10 days old, metacarpal, very commonly we see in our practice. So if you put just by AO system 1 KY, then you have to put a brace or a plaster. But in this you can just put 1 link wires on the either side and reduce it by 1 KY. It gives wonderful results. You see the results, excellent results, and from day 1 you can start doing this, the movements. Again an old fracture, intra-articular of 4th and 5th phalanx. We need to reduce this, we reduced it and put it, and you can see good results. Another one, spiral fracture of the 3rd metacarpal shaft and the 4th. Again, this can be done. This is 3 months down the line, this is 8 months follow-up. So no stiffness and a good. Even with the frame on, he can do all his activities. And you don't have to keep this frame for more than 4 to 5 weeks. Usually these phalanx and metacarpal fractures, they unite within 4 to 6 weeks. So depending upon the pattern of the fracture, you can easily plan it and do it. Now the Rolando's, Bennett's, intra-articular fractures, this works wonderfully in those cases also. So if it is a compound, you can easily do it and reduce it. The only thing is that you should know how to put the wires, what is the basic biomechanics, right? I'll quickly just wind up. So other cases, where can you put it? You see this was a trapezium fracture. So we reduced it with a K-wire, but just to offload the joint, we have just put the JESS fixator. So no need of any plaster, anything. So it gives wonderful results. Okay. You can use it in crush injuries. Okay. You can use in multiple cut injuries. You can put a positional functional frame and you can ask the patient to mobilize from day 1, right? So quickly, one blast injury we treated, at least he could save his thumb and he could do good functions. So the take-home message is, it is readily available. You all should have this system whenever you are operating any type of a fracture, because it can easily bail you out from any condition. That I can assure you. Second is, it is very cost effective. It is quick to apply. It's a reliable tool and it is very, very modular. And at the end, it is made in India. Thank you very much.